pretty much tense timing nowadays. I do understand that you may be quite stressed, and trust me, the time that you're gonna spend with this FMGE Sprint series is going to be worthwhile, because this is not about being a very didactic teaching lessons or trying to talk about things which are maybe important when you are in the beginning of your preparation, but when the exam is just around the corner, probably we don't need to waste too much time on that. So what I'm going to do today is I will be probably giving you around 40 to 50 golden points which are of extreme high yield and are of importance when it comes to the FMGE examination. Okay, so the focus is only on the points. We don't have any questions. Maybe we will touch upon some images, but we don't have any questions, because at this point of time trying to solve questions may be counterproductive, so rather try to remember the important golden points. We will begin system wise, so we'll start with one system at a time. Okay, so the first system we will be taking up is gastroenterology. And within the gastroenterology, the first topic I would probably talk about is peptic ulcer, gastroenterology, and within that the first topic of interest will be peptic ulcer. And when it comes to peptic ulcer, you should tell me what are the two most common causes for peptic ulcer. That would be the first point, right? Peptic ulcer. What are the two most common causes? That can be the MCQ. What is the first most common cause and what is the second most common cause? The first most common cause, please remember, it is always going to be H. pylori, whether you talk about the Western population or whether you talk about Indian population, that will be H. pylori. And the second most common cause will be NSAIDs, right? Okay, so those are two important MCQ point. The third important MCQ point they will ask you is what is the most common complication of peptic ulcer, right? So the most common complication of peptic ulcer is what? The most common complication of peptic ulcer disease or peptic ulcer would be bleeding of the peptic ulcer. It is not perforation. Perforation is obviously not that common in today's context where the use of PPIs is very common. So don't worry about the perforation. Always answer bleeding peptic ulcer. That is the most common complication. Okay. What else you need to know? They will ask you about the treatment of H. pylori infection. They will also ask you about the diagnosis of H. pylori infection. Diagnosis, I'm pretty much sure it will be covered in microbiology. So let me talk to you about one or two important points about the treatment of H. pylori infection. So when it comes to the treatment of H. pylori infection, you are familiar with the drug regimens like the triple drug regimen, quadruple regimen, right? Sequential regimen, load regimen. Now what I anticipate this time examiners would ask is what is the current recommendation when it comes to Indian patients with the H. pylori infection. So what is recommended right now? Recommended in India. Do we think we should be giving a triple drug regimen to patients diagnosed with H. pylori positivity in India? No. The recommended regimen is quadruple regimen, which must contain a bismuth. So the recommended regimen is bismuth containing quadruple regimen. Okay, why is this regimen recommended over triple drug regimen? Okay, so that brings one important MCQ point. When we talk about the drugs, why are we using the multiple drugs in case of H. pylori? Because the higher incidence of resistance, right? So resistance is a concern. Now, if the resistance is a concern, to overcome that we are giving multiple drugs. Then the question is, which drug is showing the maximum resistance, right? That can be another MCQ. Okay, so the drug with max reported resistance are mainly two drugs you need to remember. One is clarithromycin and the second one is metronidazole. Clarithromycin and metronidazole. Why clarithromycin resistance? Because the macrolides like azithromycin, erythromycin, clarithromycin, roxithromycin are used left, right, center in many countries including India for unwanted indications, and because of that the resistance is already high. Now what world guidelines recommend is when the resistance is more than 15%, please do not use clarithromycin based regimen. In India, most of the geographical location, you talk about any part of the country, generally the clarithromycin resistance for H. pylori is more than 15%. That is why we are not using clarithromycin containing triple drug regimen. We are using quadruple regimen. And if we are using bismuth containing quadruple regimen, they might as well ask you what are the components of this bismuth containing quadruple regimen. Okay, so we should certainly know the components. What should be there in those 4 drugs? Okay, pretty easy to remember. There is a simple mnemonic. I would rather say OBMT. OBMT. So where O stands for omeprazole, which is a PPI, right? Omeprazole. B stands for bismuth, bismuth subsalicylate or bismuth citrate, any bismuth salt. M stands for metronidazole, and T stands for tetracycline. So this is the preferred or first line medication when it comes to India. This is the recommended regimen currently. We no longer stick to using triple drug regimen. What else they will ask you? They will ask you the duration of therapy, right? Duration of therapy. The duration of treatment is 10 to 14 days. We should be giving these medications for 10 to 14 days. Okay, so I hope the point is clear. Now coming to the next important topic, what else can be asked from the gastroenterology? Peptic ulcer, these are the important golden points. Okay, after peptic ulcer, the rest of the things are mostly from the surgical side. So let me move to the hepatology. Okay, so when it comes to the liver, the first important MCQ point is they will ask you what is the most common cause for chronic liver disease or chronic liver failure or cirrhosis, right? So right now the most common cause for cirrhosis or CLD, if you're thinking alcohol, the answer is no. Alcohol is no longer considered as the most common cause for cirrhosis of liver. Right now it is the non-alcoholic fatty liver disease, NAFLD, right? Non-alcoholic fatty liver disease is the most common cause for cirrhosis of liver. Alcohol comes the second. Okay. Now what else they can ask you about liver? They will ask you what is the most common cause for acute liver failure? Most common cause for acute liver failure. I'll tell you what is acute liver failure because that definition itself is an MCQ point. But for now, what is the most common cause for acute liver failure? I will be giving you 2 points to remember here when it comes to India and when it comes to the world. World over, when it comes to acute liver failure, the most common cause is drugs. Okay. But in India, it is not drugs. It is viral hepatitis. It is viral hepatitis. Viral hepatitis in India is the most common cause for acute liver failure. And if we are talking about viral hepatitis, then comes the question, which virus? We know A, B, C, D, E, right? Among them, which one is the most common cause for acute liver failure? So among them, the most common one is hepatitis E. Hepatitis E is the most common cause among the viral causes, among A, B, C, D, E, and other than that non-hepatotropic viruses all clubbed together. Hepatitis E is the most common cause for acute liver failure in India. Okay, now talking about the drugs as a cause worldwide, right? What is the most common drug? Among the drugs which can cause acute liver failure, the most common drug worldwide is paracetamol. Paracetamol poisoning is the most common cause for drug-induced acute liver failure, and worldwide that is the most common cause for liver failure. Okay. Now what else they will ask you? They will ask you what is the second most common cause for acute liver failure in India. First to pata hai, right? First one is viral hepatitis. Within viral hepatitis, it is hepatitis E. After viral hepatitis, what is the second most common cause for acute liver failure in India? What do you think? Let me give you a clue. It is drugs. Okay. So when it comes to second most common cause, it is the drugs. So drug induced liver failure is the second most common cause for the acute liver failure in India. Now tell me which drug. Is it paracetamol or something else? In India, for some unknown reason, the paracetamol toxicity is less commonly reported compared to the Western world. So what we see here is like one disease, which is an infectious disease, which is pretty common in India, and the drugs we use to treat that particular infectious disease are hepatotoxic. So now tell me which disease I'm talking about. Right, so we are talking about, among the drugs in India, the most common cause are ATT, right? ATT. Okay, so if you're talking about ATT, they might as well ask you among the 4 standard common first line agents, which drugs are hepatotoxic. Okay, so ethambutol is not hepatotoxic. Rifampicin can occasionally be hepatotoxic. So the other 2 drugs, right, they are potentially hepatotoxic. Okay. Now coming to the definition of acute liver failure is again an important MCQ point. Definition of acute liver failure. How do you define acute liver failure? What is acute liver failure? See, so many patients develop jaundice, so many patients develop hepatitis, liver dysfunction. We don't call all of them as having liver failure. So there has to be a standard definition. Definition is development of hepatic encephalopathy. So all of us know what is hepatic encephalopathy, right? Development of hepatic encephalopathy within dash days or weeks of onset of jaundice. Onset of jaundice. Now tell me the answer. See, first symptom is most likely jaundice, right? For most patients with liver disorder, jaundice will be one of the initial symptoms. From the day they develop jaundice to the development of hepatic encephalopathy, how much time patient has spent before he has developed hepatic encephalopathy. That duration defines whether we call it as acute liver failure or chronic liver failure. Okay. Now there are 2 points here. Point number 1, if you are going by Indian guidelines, then it is 4 weeks. If patient develops encephalopathy within 4 weeks of the onset of jaundice, we will call it as acute liver failure. This is Indian guidelines. American guidelines is 26 weeks. Okay. So 26 weeks, this is according to American Association for Study of Liver Disease, and according to India, according to Indian National Association for Study of Liver, it is 4 weeks. So if patient develops encephalopathy within 4 weeks of the onset of jaundice, then it is acute liver failure according to Indian guidelines. We need to remember both of these because we don't know which one the examiner will be following. Examiner might ask you according to India what is it, or according to AASLD what is it. So remember both. 26 weeks according to America, 4 weeks according to India. Okay. Now that is about the definition of acute liver failure. Okay, so now from there, let me take you to another important small topic from the hepatology, that is the autoimmune disorders of the liver, right? Autoimmune hepatobiliary disorders. And among the autoimmune hepatobiliary disorders, we will talk about 3 important disorders. The first one is autoimmune hepatitis. Okay, what you need to know about autoimmune hepatitis? So the first one is autoimmune hepatitis. Mostly they will ask you about the types of autoimmune hepatitis. So please remember there are 2 types of autoimmune hepatitis, type 1 and type 2. Okay, so what they will ask you is which antibody is typically suggestive of type 1 and which antibody is typically suggestive of type 2. Okay, so for type 1, the antibody that is suggestive of type 1 is ANA. And the antibody that is suggestive of type 2 is anti-LKM1, anti-liver kidney microsomal 1 antibody. Okay, so this is an extremely important MCQ. They might ask you this, like there is a patient who presented with repeated episodes of jaundice, viral hepatitis workup is negative, and we are suspecting the possibility of autoimmune hepatitis. We have done this antibody profile. So what is the diagnosis? Is it the type 1 autoimmune hepatitis or is it type 2 autoimmune hepatitis? So type 1 is when ANA is positive, right? So where do we typically talk about ANA? SLE, right? Lupus erythematosus. So that is why type 1 is also called as leukemia hepatitis, because this is typically associated with SLA. It is associated with SLA. Okay. Type 2 is not associated with SLA. Okay. Now they will also ask you about the treatment of autoimmune hepatitis, right? So when it comes to treatment of autoimmune hepatitis, remember the first line medications are steroids. First line agents are nothing but oral corticosteroids. Oral corticosteroids. So if the patient is not responding to steroids, we do add immunosuppressant, but the starting point is usually steroids when it comes to autoimmune hepatitis. Okay. Then the second autoimmune disorder of the hepatobiliary system that we're talking is nothing but what is called as primary biliary cholangitis. Primary biliary cholangitis. Okay. So now what do you mean by primary biliary cholangitis? As I've already told you, this is also a condition where you have an autoimmune disorder, but the disorder is not primarily affecting the hepatocytes or liver cells. It is affecting the biliary tract. That is why in the name itself we have biliary cholangitis. Okay. This disease was earlier known as primary biliary cirrhosis. Primary biliary cirrhosis. Now we have abandoned the terminology, but sometimes examiners might give you that term for you. So please be aware that both mean same. PBC here, PBC there, both are same words. Okay. Now what you need to know about primary biliary cholangitis? Number one, it is an autoimmune disorder. It is affecting what? It is an autoimmune disorder that is affecting small and medium sized bile ducts. Okay. Now if I pose a question and ask you, like, if there is a disorder which is affecting small and medium sized bile ducts, will it be causing intrahepatic cholestasis or extrahepatic cholestasis? See, when bile duct is damaged, the bile flow through that will be affected, so there will be cholestasis, right? Now these small and medium sized bile ducts are there within the liver or outside the liver. See, you remember this liver anatomy, right? You draw something like this, you draw a gallbladder, then you draw a bile duct coming from the liver, and then the bile duct from the gallbladder, a common bile duct joining the duodenum. Where are the small medium bile ducts present? They are present inside the liver, right? Large bile ducts are present outside the liver. So if it is an affecting small and medium sized bile ducts, it essentially means that it causes intrahepatic cholestasis. It causes intrahepatic cholestasis. Okay. So they can ask you this question, whether this is a condition characterized by intrahepatic cholestasis or extrahepatic cholestasis. It is a condition characterized by intrahepatic cholestasis. The second point they will ask you is, what is the most common symptom? Most common symptom of patients with primary biliary cholangitis is going to be, tell me what could be the symptom. It is an autoimmune disorder causing cholestasis. When cholestasis is there, patient can develop pruritus or itching. But even before the pruritus starts, patients develop fatigue. So fatigue is the most common symptom, and second most common symptom is itching or pruritus. Second most common symptom is itching or pruritus. Okay. Now after this, yes, the other symptoms like jaundice, and the condition can progress to cirrhosis. So patients may develop cirrhosis. Once they develop cirrhosis, they will have manifestations of cirrhosis like gynecomastia, spider angiomatas, palmar erythema, right, Peter hepaticus, and if they have developed hepatic encephalopathy, the flapping tremors, ascites, pedal edema, engorged veins on the abdomen, splenomegaly, all the manifestations of cirrhosis may be evident in a later stage. Okay, so the last point you need to know about is the drug of choice for treatment. Drug of choice for treatment of primary biliary cholangitis. It's not steroids. Yes, it is an autoimmune disorder, but there is no role of steroid. There is no role of immunosuppressants. The recommended drug is ursodeoxycholic acid. Ursodeoxycholic acid. Okay, so this is the drug of choice. This is a question which has appeared in the past multiple times, so I would expect you to remember it. And then there is one new drug which has been introduced in the recent past. as a second line agent, and that becomes an important pharmacology question. They might ask you what is this newly approved drug for primary biliary cholangitis, and they can ask you about its mechanism, right? So the second line agent, which is an add-on. That means we will start ursodeoxycholic acid, but if you're not getting the results we want, then we will add this second line agent. And what is that? The name of the agent is obeticholic acid. Obeticholic acid, that's the name of the agent, obeticholic acid. Okay, its mechanism of action is going to be an important MCQ point. Mechanism of action of obeticholic acid is nothing but it is a farsenoid X receptor agonist. Farsenoid X receptor agonist. Okay, so this is all you need to know about the primary biliary cholangitis. Now, what do I expect more from the autoimmune disorders of the liver and the biliary tree? They will expect you to differentiate between primary biliary cholangitis and primary sclerosing cholangitis. Two confusing terms, right? Okay, so let us talk a little bit about what is called as primary sclerosing cholangitis. Primary sclerosing cholangitis, or PSC. Sclerosing cholangitis or PSC. Okay, this is also an autoimmune disorder. When we say cholangitis, it is affecting the bile ducts. The difference is it is an autoimmune disorder which is affecting both small, medium as well as large bile ducts. An autoimmune disorder affecting small, medium and larger components of bile ducts. Okay, so this is a condition where you have both intrahepatic as well as extrahepatic cholestasis. So this leads to both intra plus extrahepatic cholestasis. Okay, so that is one difference. Now, if there is extrahepatic cholestasis, can we confirm it with imaging? Yes. So intrahepatic cholestasis cannot be confirmed with imaging, but extrahepatic, see, imagine if this is your liver, right? This is your bile duct joining your duodenum. If there is an obstruction here, right? So pressure of inside all the bile ducts which are draining towards this extra bile duct, outside bile duct, will increase. So all these intrahepatic biliary radicals will get dilated. So whenever you see an ultrasound or MRCP or ERCP showing dilated intrahepatic biliary radicals, it is suggestive of extrahepatic cholestasis or obstruction. So on imaging, in these patients, on imaging, we might see dilated intrahepatic biliary radicals. We will not be seeing that in patients with primary biliary cholangitis. So in these patients, if you do an ultrasound, you may find nothing until and unless patient goes cirrhosis, you may find nothing. Okay, so we'll see dilated intrahepatic biliary radicals. Okay, now the last point. Pathophysiology wise, we know what is the difference, right? So primary biliary cholangitis is a disorder affecting small, medium bile ducts, and your primary sclerosing cholangitis is affecting entire biliary tree, right? So when I say large, medium, small, it means like entire biliary tree. Okay, so because it is affecting entire biliary tree, it causes extrahepatic cholestasis also. So we might see dilated intrahepatic biliary radicals. See, both of them are autoimmune disorders, right? So do we have evidence of any antibodies in these patients? They will ask you, this antibody is characteristically seen positive in which disorder? So the characteristic antibody that we see in primary biliary cholangitis, the antibody that we see in primary biliary cholangitis is anti-mitochondrial antibody. Anti-mitochondrial antibody. Okay, this is a very, very important diagnostic clue. Any question that talks about positive AMA and talks about liver dysfunction, think about only primary biliary cholangitis. Only primary biliary cholangitis. Okay. Next, the antibody that we see in primary sclerosing cholangitis. I will give you a clue. This disorder, primary sclerosing cholangitis, is closely associated with ulcerative colitis. So which antibodies we see in ulcerative colitis? Which antibody we see in ulcerative colitis? Right. So when it comes to the antibody in primary sclerosing cholangitis, you have to remember that the antibody is going to be what? It will be P-ANCA. It will be P-ANCA. Okay. So if the question talks about liver dysfunction, patient being a case of ulcerative colitis and P-ANCA positive, you know the case is primary sclerosing cholangitis, right? So this is one additional point to remember. Strong association with ulcerative colitis. Okay, now in terms of treatment, they can ask you what is the drug of choice. So the drug of choice here as of now is still same, the ursodeoxycholic acid. Ursodeoxycholic acid. Okay, so that kind of quickly completes our discussion on the gastroenterology section. What we have touched upon, a little bit about peptic ulcer. We have gone here and there about the drugs. Then we have touched about some basic questions from the hepatology. Okay, I'm skipping the inflammatory bowel disease because that will be covered by my surgery colleague. Now we will move to the next system. The next system we are going to talk about is respiratory system. Okay, now when it comes to respiratory system, the first most important disease will be bronchial asthma, right? So let me talk about asthma first. The first MCQ point from asthma from the examiner would be, what is the investigation of choice for diagnosis, right? What will be the investigation of choice for diagnosis of bronchial asthma? So the investigation of choice for diagnosis of bronchial asthma is spirometry or PFT, right? Spirometry or PFT. Okay, now sometimes the examiner can get cranky and ask you little beyond this. Okay, spirometry is not available. Like it's a situation in a resource limited country, poor country, where spirometry is not practically possible. What can be used for the diagnosis of bronchial asthma, right? So the investigation of choice in the absence of or contraindications for spirometry, because sometimes there can be contraindications also for spirometry. Like for example, during COVID pandemic, doing spirometry was risky, right? You ask the patient to blow air into a pipe, then he will blow into the environment, and the people who are taking care of the setup will also get exposed. So that was a contraindication. So whenever there is a contraindication for spirometry or spirometry is not practically possible, it is not there, in those cases the investigation of choice would be peak expiratory flow rate. Using PEFR we can make a diagnosis, but the diagnosis of asthma is never purely clinical, right? It is always supported by either PFT or PEFR. Okay, now the next point that the examiner may be interested to know is the diagnostic criteria for asthma, right? So what is the diagnostic criteria? Diagnostic criteria. So on the PFT there are only two parameters which are important for us. The parameter number one is your FEV1 and the parameter number two will be FEV1 by FVC ratio. These two are more than sufficient for us to make a diagnosis of the initial diagnosis of bronchial asthma. I'll tell you how to differentiate it from the COPD. So in patients with bronchial asthma, the FEV1, forced expiratory volume in 1 second, will be reduced, right? It will be decreased. Okay. Now the FEV1 by FVC ratio, normal is how much? Normal is more than 0.7. Normal FEV1 by FVC ratio is more than 0.7. In bronchial asthma, it will be decreased. So it will be less than 0.7. Okay. Now whenever your FEV1 by FVC ratio is less than 0.7, it basically means patient has got an obstructive lung disease. It is equal to obstructive lung disease. Asthma is not the only obstructive lung disease, right? We can go on making a list, but the second most important obstructive lung disease is COPD. Now we have to make an attempt to differentiate this from COPD, because in COPD also your FEV1 will be reduced, your FEV1 by FVC ratio will be less than 0.7. So how to distinguish it from COPD, right? That's the next important point. So for that we can look at two parameters. The parameter number one is what is called as bronchodilator reversibility test. Bronchodilator reversibility test, or BDR test. Okay, so the BDR test is done to differentiate between asthma and COPD. Asthma and COPD. How will this help me to differentiate between asthma and COPD? See, the asthma is a condition where there is reversible bronchial obstruction. COPD is a condition where there is persistent bronchial obstruction. Both are bronchial obstruction disorders, but in asthma the obstruction is reversible by giving a bronchodilator. In COPD we will not be able to completely reverse it by giving a bronchodilator, and that is what we are trying to prove in this test. So in this test, how do we interpret? Okay, if FEV1 of the patient increases by more than 12% or by more than 200 ml, right, it is suggestive of asthma. Okay, and if it doesn't increase that much, right, it might increase but the increase is less than 12% or less than 200 ml, then it is suggestive of COPD, right? So basically what do I mean? When we do this bronchodilator reversibility test, if it is asthma, the patient's FEV1 will improve by more than 12%. If it is COPD, it may improve but not by more than 12% for sure. It will be like less than, like 4%, 5% improvement you might see. So that is why this is the most important investigation to differentiate between asthma and COPD. Okay, what else will help us to differentiate between asthma and COPD? So the second test that can help us to differentiate between asthma and COPD is diffusion capacity of the carbon monoxide. Okay, so the DLCO in COPD, let me put small table here so that you will be able to remember the differences between asthma and COPD. That's a potential MCQ area for all of us. So let us do a quick small table so that we will not forget. Few PFT parameters. First is FEV1. What happens to FEV1? What happens to FEV1 by FVC ratio? What happens in bronchodilator reversibility test, and what happens in DLCO? Okay, FEV1 will be decreased in asthma, so is the case of COPD. FEV1 by FVC ratio will be decreased in both cases, that means less than 0.7, because both of them are obstructive lung disease. So that is why these two tests are the ones which will help us to differentiate mainly. So bronchodilator reversibility test shows FEV1 increases by more than 12% in asthma. In case of COPD, no increase in FEV1, or if increase happen, it is less than 12%, right? It will be less than 12%. Now talking about the DLCO, diffusing capacity of carbon monoxide, in case of asthma, this will either be normal or sometimes increased, because asthma, the airway is inflamed and the cells they do not, like, the vascularity of the cell, the tissues also increases, so that facilitates more transfer of gas across the inflamed membrane. Just like how meningitis can breach the blood-brain barrier, here the barrier is breached by inflammation. That is why DLCO can be increased in asthma. In COPD, the DLCO will invariably be decreased. It will be decreased. Okay. Now guys, please remember this point, because this is, according to me, one of the potential MCQ point for this time, the DLCO difference between asthma and COPD. Okay. Now what else they will ask about asthma? I'm not going into the pharmacotherapy of asthma. Okay. The only next important area of asthma that I want you to remember is the phenotypic classification of asthma. That is another important MCQ area. Okay, so asthma is classified in various ways. My pediatrics colleague might classify asthma into atopic and non-atopic, or intrinsic and extrinsic asthma. But as a physician, adult practitioner, my approach to classify asthma would be classify asthma into type 2 and non-type 2 asthma. So we will classify asthma into type 2 and non-type 2. Okay, why is it called as type 2 asthma? In type 2 asthma, the inflammatory cells which are responsible for causing the asthma are mainly the Th2 cells. So in type 2 asthma, it is Th2 or helper 2 T cell mediated, Th2 cell mediated inflammation. In case of non-type 2, it is the Th1 and T helper cells type 1 and 17. Those are the principal mediators. Okay, so that is first point you should know to differentiate between these two. Then you should also know what is called as effector cells involved in type 2 asthma. Means Th2 cells will trigger the inflammation, but the formal work of inducing the inflammation is carried forward by other cells, right? So what are those cells? Mainly here the important cells are eosinophils. In case of the non-type 2, it is neutrophils. Here it is eosinophils, there it is neutrophils. Okay. The third point you need to know about the type 2 versus non-type 2 is the inflammatory cytokines involved in the pathogenesis process. Inflammatory cytokines involved in the pathogenic process. Okay, so when it comes to the type 2, it is interleukin 4, interleukin 5. These are predominantly important inflammatory cytokines that are involved. In case of the non-type 2, it is IL-1 and IL-17, interleukin 1 and interleukin 17. Now, why this classification is important may be one of your question, right? Okay, from pharmacology, you study about certain drugs like the dupilumab, restlimumab, mepolizumab, omalizumab. Now, all those monoclonal antibodies are mainly targeting these cluster of inflammatory cytokines. Okay, so I should just add IgE also. So that is why with the modern drugs, it is more easy to treat the type 2 asthma. Modern drugs or biologicals as of now are not greatly effective for the non-type 2 asthma because we don't have precise drugs targeting interleukin 1 or 17 in the respiratory tract. Okay. Now coming to, just few points guys about, because we're talking about all these inflammatory cytokines involved. Let us talk about some drugs, right? Drugs targeting these. Okay, so there is one drug called as dupilumab. Okay, then there is another drug called as restlimumab. These are all monoclonal antibodies. Okay, then we have a drug called as benralizumab. And finally a drug called as mepolizumab. So their mechanism of action or which particular inflammatory cytokine these drugs are targeting can be a question. So dupilumab, the drug, this is targeting interleukin 4, right? It is not directly targeting the interleukin 4, it is targeting the interleukin 4 receptors. Okay. Then mepolizumab and restlimumab, these are targeting interleukin 5. And benralizumab is targeting interleukin 5 receptor. It is targeting interleukin 5 receptor. Okay, we shouldn't be getting confused here. This is pretty easy to remember. You know, D is the fourth letter of the alphabet and interleukin 4 is the fourth, right? 4. So 4 for D, remaining all you can think of as related to interleukin 5. Okay, now there is one last drug to be added here, and that is omalizumab. which is not targeting a interleukin, rather it is targeting an immunoglobulin, right? So which immunoglobulin is involved in the pathogenesis of type 2 asthma? IgE, right? So omalizumab is targeting IgE. So this is an anti-IgE monoclonal antibody. Mepolizumab is anti-IL-5 monoclonal antibody. Benralizumab is an anti-IL-5 receptor monoclonal antibody. Restylizumab is an anti-IL-5 monoclonal antibody, and dupilumab is anti-interleukin 4 receptor monoclonal antibodies. So if there is a question asking you biologicals are effective in treating which type of asthma, type 2 versus non-type 2, your answer should be type 2, right? Okay. Now that was about asthma. We will now move to the COPD. Okay, so when it comes to COPD, what MCQs we can expect? First thing is, what is its definition, right? So COPD is a chronic obstructive lung disorder affecting, see, bronchial asthma is affecting small and medium sized airway, but COPD affects both small, medium as well as large airway, affecting small, medium and large airway, and also lung parenchyma. So that means it is affecting alveoli, it is affecting airway, everything it is affecting, right? So that is the COPD. And the important point here is, when we say obstructive here, this obstruction is persistent. This is a persistent obstruction, so it may not respond well to bronchodilatory medications. Asthma is a reversible obstruction, responds well to bronchodilatory medication. Okay. Now the important MCQ point is, what is the most common cause for COPD? Most common cause for COPD is tobacco smoke exposure, right? It may be smoking or other forms, like any other form of tobacco smoke exposure. So most common cause is tobacco smoke, and obviously the most common way of consuming the tobacco smoke is smoking cigarettes and BDs. Okay, this to pata hai. What I can expect as a googly MCQ is, what is the most common cause for COPD in non-smoker females? Non-smoker females. Some of you might say, sir, passive smoking. No, that's not the answer. There is an India specific cause for the COPD in non-smoking females. So what is it? Most common cause for COPD in non-smoking females. Most common cause for COPD in non-smoking females. Okay, the answer should be burning of biomass fuel, chula, right? So that smoke exposure is the most common cause for COPD in females. So you might see a lot of females, especially if you're in a government medical college or a peripheral college, and you will see that females also get diagnosed with COPD, and you might get history suggestive that none of the family members are smokers, neighbors are not smokers, and don't know how she got the COPD. Probably because they are using chula, right? They are burning the biomass fuel, right? Cow dung is used to make those patties and then used as a fuel, or this small wooden twigs. So burning biomass fuel, right? So let me call it as chula so that you remember it, right? That's the most common cause for COPD in females. So ये हो गया causes के बारे में, right? Now they will also ask you, how do you make a diagnosis of COPD, right? So the diagnosis of COPD will be based on PFT plus imaging. Okay, imaging can help in the diagnosis. So PFT में क्या दिखेगा हमको? In the PFT we will see that FEV1, forced expiratory volume, will be decreased. That is common just like in patients with asthma, right? Then FEV1 by FVC ratio, which suggests obstruction, will be less than 0.7, just like in case of asthma. Then how is it going to be different? I just told you a couple of minutes back. I will do bronchodilator reversibility test. I will give a short acting bronchodilator inhalation and I will recheck the FEV1. So if FEV1 increases by more than 12%, I will call it as asthma. If it increases by less than 12%, right, then I will call it as increase less than 12%. Anywhere 0 to 12%, I will call it as COPD. and if I want, I can do diffusing capacity of carbon monoxide, which will be decreased, right? Okay, and if I do chest x-ray, what are the findings I'm gonna see in a case of COPD? See, especially I will see findings in patients with emphysema type of the COPD, where there is air trapping in the lungs, and because of that the diaphragm is flattened down. So that will be one of the finding, right? Flattened diaphragms, flattened diaphragm. Second finding I will see is once the air is trapped in the lungs, right? It's an obstructive lung disease. They are finding it difficult to exhale. So the air is getting trapped in the lungs. So the net result is the lung volume expands. So obviously the rib spaces will widen. So we will see widened rib spaces. Then the third thing we will see in these patients is what happens to the heart when the lungs are expanding. The space available for the mediastinum is shrinking. So heart takes a particular look, right? What we call this look as tubular heart, right? We call it as tubular heart. So these are the important findings we will be seeing on the chest x-ray. So basically heart is getting shrunk because lungs are expanding. Because lungs are expanding, diaphragm is getting pushed down, and because lungs are loaded with air which they are not able to exhale out, lungs become much more darker, right? Lungs become much more darker. Okay, so this is about COPD. Again, it will not be apt for me to now get into the pharmacology of COPD. That will be definitely dealt in the pharmacology session. Okay. Now the next disease we are taking up from the respiratory medicine is more of inching into the critical care medicine, that is ARDS. Okay. Now from ARDS, what they will ask you? First thing they will ask you is what is the current diagnostic criteria. They will ask you what is the most common cause for ARDS, how do you classify causes for ARDS, and what are the ventilatory settings. This will take only 5 minutes for us to quickly revise. First thing is the diagnostic criteria that we currently follow. The diagnostic criteria that we currently follow for ARDS is called as Berlin criteria. Berlin criteria. Okay. How do you diagnose the ARDS based on Berlin criteria? That's extremely important. I'll come back to this point. But before that, other important points like what is the classification of causes for ARDS? Classification of causes for ARDS. Okay. How do you classify the causes for ARDS? We classify them into two broad groups. Okay. So the first group is we call them as intrinsic causes, and the second group we call them as extrinsic causes. So when I say intrinsic, that means the problem is inside the lung. When I say extrinsic, the problem is outside the lung. Something outside the lung affecting the lungs indirectly, that is extrinsic. Something inside the lung affecting the lungs is intrinsic. Okay. So not going into the detailed list of intrinsic extrinsic causes, they will ask you mostly what is the most common intrinsic cause for ARDS, what is the most common extrinsic cause for ARDS. So the most common intrinsic cause for ARDS is pneumonia. Pneumonia is the most common intrinsic cause for ARDS, and the most common extrinsic cause where the problem is not starting with the lungs, it starts somewhere else and then lungs get caught up in the fire, that is sepsis. Sepsis is the most common extrinsic cause for ARDS. Both of these are potential important MCQ points. Okay. Now how do you diagnose ARDS according to Berlin criteria? Okay. So according to Berlin criteria, we need to meet 4 important requirements. The first important requirement is hypoxia. Right. To call it as acute respiratory distress, it should be acute. There should be respiratory distress, and the distress is because of hypoxia. So how do you define hypoxia here? So for defining hypoxia, just taking SpO2 or simple ABG is not enough. We will be looking at PaO2 by FiO2 ratio. Okay. So this ratio in normal circumstance is more than 400. Okay. And when it is less than 300, we will call it as ARDS. In normal situation, it is more than 400. When it is less than 300, we will use it for defining the ARDS, and this ratio can be used to classify the severity of ARDS as mild, moderate and severe. So when this ratio is between 300 to 200, that will be called as mild, and when it is between 200 to 100, that will be called as moderate, and when PaO2 by FiO2 ratio is less than 100, that will be called as severe. Okay, some cranky examiner might like to ask you, what was the previous name of this mild ARDS? So mild ARDS was also known as, acute lung injury. Instead of calling it as mild ARDS, in the past we used to call it as acute lung injury. Now we call it as mild ARDS, but the previous definition used to be like ALI, or acute lung injury. So that is one criteria. Patient should have hypoxia, and that should be measured using PaO2 by FiO2 ratio. If the ratio is less than 300, this criteria is ticked. Okay. The second criteria is on imaging. So imaging can be in the form of either chest X-ray or CT thorax, HRCT. Okay. So in the imaging, there should be bilateral. I'm highlighting the bilateral here because if you have a patient where there is unilateral opacities on the chest X-ray, it is less likely to be ARDS. So there should be bilateral alveolar opacities. That cannot be explained by other causes like pneumonia or something like that. It should be like alveolar opacities, and bilaterality is the most important point here. Okay, so that is the second criteria. Now the third criteria, see, if you see a patient with bilateral alveolar opacities, what are your differential diagnosis? My differential diagnosis will be pulmonary edema because of heart failure. Second will be like CLD or CKD, fluid overload state causing pulmonary edema. Then third will be ARDS. Now how to differentiate? Because pulmonary edema can happen in ARDS, can happen in heart failure also. We need to rule out heart failure as a cause for ARDS. So for that we need an investigation. In the past, that investigation used to be what is called as pulmonary capillary wedge pressure measurement. No longer we follow that. So, right, cardiac cause ruled out, right, using either 2D echocardiogram or invasive monitoring. So invasive monitoring is not mandatory anymore. We don't need to do this Swan-Ganz catheter, calculate pulmonary capillary wedge pressure, is no longer required. Okay, all you need to do is do a 2D echo, and 2D echo should be normal. When it is normal, it means there is no cardiac cause for pulmonary edema. Okay. Fourth point is extremely important. That is a temporal correlation between the triggering event and development of symptoms. Temporal relationship between trigger and ARDS onset. See, we spoke about like when we were talking about the causes for ARDS, right? I told pneumonia is the most common intrinsic cause, sepsis is the most common extrinsic cause. So if sepsis has happened now and patient presents 1 month later with breathlessness, should I think of ARDS? Okay, ARDS is possibility, but this sepsis cannot be the cause for that ARDS, right? Similarly, like road traffic accident happened last year and this year patient presented with shortness of breath. If he has ARDS, you cannot link it to what happened last year, right? So there should be some temporal correlation. It has to be time bound. And that time boundness in the definition is less than 7 days. Less than 7 days. So the diagnosis of sepsis, within 7 days, a patient becomes breathless and develops all these characteristic imaging findings, hypoxia, then I will call it as ARDS. If after 7 days, it is less likely to be ARDS, right? And we recognize this diagnostic criteria as Berlin criteria. Okay, so now we know the diagnostic criteria, we know the causes, right? The question now is, how do you treat, right? We all know ARDS is associated with very high mortality, and if there is a question asking you, what is the treatment of choice for ARDS, right? It is not steroids, it is not antibiotics, right? It is none of them, right? The treatment of choice or management of choice for ARDS is mechanical ventilation. Mechanical ventilation is the treatment of choice for ARDS. Okay, if you remember this much, it is kind of enough with respect to the management of ARDS. Few extra points about the ventilatory settings in ARDS. This had been a repeatedly asked question in the NEET PG, and this template can be important even for FMGE students. Ventilatory settings recommended. Okay, I'm not going to explain everything right now. It's not the time to learn something conceptually. Try to remember maximum points so that you can vomit out in the exam. Okay, ventilatory settings, what is recommended? First point is the tidal volume. Should we give high tidal volume or low tidal volume? So tidal volume, recommended strategy is low tidal volume. Low tidal volume. So when I say low tidal volume, how much? How much can be considered as low? In a normal patient who doesn't have ARDS, and if he requires ventilator setting, we give around 10 to 12 ml per kg of his body weight as the tidal volume. But if the patient has got ARDS, we cannot give that much, right? So here it will be around 6 ml per kg body weight. That will be the tidal volume for the patient. We will call it as low tidal volume. Okay. Second point they would ask you is PEEP. Whether you need to keep a high PEEP or low PEEP. What is PEEP? Why we are going for high PEEP? And all, don't think right now. Just be aware that what we need to follow. We will be following a high PEEP strategy. High PEEP strategy. Okay. Then the next point you need to know is with respect to plate tube pressure. So the plate tube pressure should be less than 30 centimeters of water. Okay, these are 3 points. Then 2 more extra points. What else can be done for patients with the ARDS? If these settings are not helping, the 3 important points where I spoke about, if these settings are not helping, what extra can be done? Okay, so prone position ventilation is recommended for moderate ARDS, and there is a treatment called as ECMO, right? Extracorporeal membrane oxygenation. If lung is not able to put the oxygen into the blood, we will directly put the oxygen into the blood. That's the basic thing. ECMO means extracorporeal membrane oxygenation. Blood goes through a machine just like dialysis machine, and when the blood is traveling through the machine, we add oxygen to it and then it goes back to human body. So this is recommended for severe ARDS. Severe ARDS. So you're already familiar with what is moderate and severe, right? So moderate is when your PaO2 by FiO2 ratio is between 200 to 100, and when it is less than 100, it will be called as severe. So if it is severe, we can consider putting the patient on ECMO. If it is moderate, we can consider patient going for the prone position ventilation. Mild cases, these many settings are more than enough. Okay, so this was about the ARDS. Okay, then the next disease we will be talking about from the respiratory medicine is interstitial lung disease or ILDs. Interstitial lung disease or ILDs. Okay, what is interstitial lung disease? A disease which is affecting the interstitium of the lung, or in other words, the lung parenchyma. So what includes in the lung parenchyma? Alveoli and connective tissue. So if there is a disease that affects alveoli or connective tissue, we can call it as interstitial lung disease. So in question, what can be asked? They will ask you what is the most common type of chronic interstitial lung disease. Most common type of chronic interstitial lung disease. The most common type of chronic interstitial lung disease is idiopathic pulmonary fibrosis. Idiopathic pulmonary fibrosis, that is the most common chronic ILD. Okay, then what else they will ask you about ILD? In the classification, there is a classification of ILD as ILD of known cause and unknown cause, and in the unknown cause there are some sub classifications. One of them is smoking related ILDs. They will ask you which of these following interstitial lung disease are considered as smoking related ILDs. Okay, so this is again a very important MCQ point. Smoking related ILDs. Okay, I want you to remember 2 conditions as smoking related ILDs. First one is desquamative interstitial pneumonia. Desquamative interstitial pneumonia or DIP. Desquamative interstitial pneumonia or DIP. And the second one is respiratory bronchiolitis, respiratory bronchiolitis associated ILD or RB-ILD, RB-ILD. Okay, so this is what is called as smoking related ILDs. Why I want you to remember? It doesn't mean that the patients who are diagnosed with other types of ILD, they do not smoke, but these two ILDs occur only in smokers. They are not known to occur in non-smokers. That is why these are called as smoking related ILDs. Okay. What else we need to know about the interstitial lung disease from the FMGE perspective? The extra point we need to know is they can ask you most common genetic abnormality in patients with ILD, or to be more precise, idiopathic pulmonary fibrosis, which is the most common type, right? So there is a gene called as MUC5 or MUC5B. So this gene mutation, this codes for mucin. Okay, so the mutation in this mucin gene is responsible for at least a substantial number of cases of the interstitial lung disease, particularly ILD. Okay. Next, they will ask you, what is the most common ILD in non-smoking females? Most common interstitial lung disease in non-smoking females. Okay, so if you're thinking, okay, let me say idiopathic pulmonary fibrosis, no, idiopathic pulmonary fibrosis is more common in males who smoke, right? So IPF, this one is typically more common in males who smoke. So this is more common in males who smoke. So now tell me which is more common in females. Right, so in females, the one that is more common is called as idiopathic non-specific interstitial pneumonia, or idiopathic NSIP, idiopathic non-specific interstitial pneumonia. That is the most common type of ILD that we will see in non-smoking females. Okay, so a little bit of comparison is required between the idiopathic pulmonary fibrosis and non-specific interstitial pneumonia, because this can be a template for MCQs, giving you information and then asking you whether this is NSIP or whether this is IP. Okay, so if we talk about the age of the affected group, right, IPF is typically more common in people who are more than 60 years. So you can obviously say that this is a disorder of the elderly people or a geriatric age group. And on the other hand, NSIP is typically more common in 40 to 50 years age group. So you can say that these are relatively young patients. So the gender preponderance wise, IPF is more common in males and NSIP is more common in females. Okay, when it comes to smoking history, right, the strong risk, smoking is a strong risk for development of IPF, right? This usually occurs in non-smokers, Okay, now how do these two things differ on the HRCT imaging? Okay, on the HRCT we get something known as usual interstitial pneumonia pattern, usual interstitial pneumonia or UIP pattern. And on the HRCT, in case of NSIP, the pattern itself is called as NSIP. So it's pretty easy to remember. NSIP pattern. Okay, so those who are not familiar with these patterns from the radiology, so let me tell you what is the clinching clue for usual interstitial pneumonia pattern and what is the clinching clue for NSIP pattern. So in usual interstitial pneumonia pattern, there will be honeycomb appearance. Honeycomb appearance. And in the NSIP pattern, there will be ground glass opacities. Ground glass opacities. Okay. The last point is regarding prognosis. Prognosis. So prognosis is poor in case of idiopathic pulmonary fibrosis. Bechara mard log, right? Males, they don't do well with respect to diseases, especially chronic diseases. Poor in case of idiopathic pulmonary fibrosis, which is more common in males. In case of females, the prognosis is good because they have this NSIP which responds well to steroids. Okay, these are the superficial points that you need to know. Last bit is about the treatment of interstitial lung disease. What you need to remember with respect to treatment of interstitial lung disease is, if it is idiopathic pulmonary fibrosis, first line agent, there are two actually, so let me call them as first line agents, and they include perfenidone, and the second one is nintedanib. So whenever we hear the word nib, we know that it is a tyrosine kinase inhibitor, right? Okay, so both of these, by mechanism of action, these are anti-fibrotic agents. So we're talking about a disease where there is fibrosis. We are giving drugs which inhibit fibrosis, anti-fibrotic agents. Okay, then second line agents are basically immunosuppressants. So you can use cyclophosphamide, azathioprine, plenty of them. Immunosuppressant can be used as a second line agent. Okay, and if you ask me about what is the definitive treatment will be lung transplantation. What else can we do? We cannot completely cure the ILD, so we have to do the lung transplantation if you want to totally get rid of the diseased lung. Okay, so that is the definitive treatment. Okay, now when it comes to the idiopathic non-specific interstitial pneumonia, which is more common in females, right? So in them, first line agents are usually steroids. Okay, and second line agents are usually immunosuppressants. There is limited role of these drugs called as perfenidone and nintedanib, which are anti-fibrotic agents. So second line agents are immunosuppressants. Okay, last point that I can anticipate from the ILD is they might ask you, what is the drug of choice, or how do you treat these smoking related ILDs? Pretty simple, guys. Quit smoking, and they show excellent response to steroids. So if it comes to treatment of smoking related ILDs, okay, now what ILDs come under this heading? I have already told you, right? This is an important MCQ point. Smoking related ILDs, what comes under this? Desquamative interstitial pneumonia, DIP, and respiratory bronchiolitis associated ILD, or RB ILD, right? So here treatment includes only two things. One is to quit smoking, and second one is steroids. They show excellent response to steroids. Most of them recover completely. Okay, two extra points about ILD. One thing is in terms of clinical examination, right? On auscultation, what characteristic sounds we hear? Auscultation findings in idiopathic pulmonary fibrosis. Okay, so we hear crackles or crepitations, which are usually described as fine end inspiratory crepitations, which sound like the opening of or attachment of velcros. So that is why they are often described as velcro like crepitations. Velcro like crepitation. Okay, any exam, if your examiner mentions the word velcro like crepitation, think about the idiopathic pulmonary fibrosis type of ILD without a second thought. There is otherwise no business examiner writing about this. Okay, you should always also pay attention to fine, because there are other conditions where you get crepitations, like bronchiectasis you get coarse crepitations. In case of the ILD you get fine crepitations. Okay. One extra bullet point about ILD is which interstitial lung disease mimics like ARDS, right? Which ILD mimics ARDS? The presentation is similar to ARDS. Your answer should be, there is an ILD called as diffuse alveolar hemorrhage. Diffuse alveolar hemorrhage, or DAH. This can also be called as diffuse alveolar damage, or DAD. Okay, so this is about the interstitial lung disease. I think we have covered the key important MCQ points and what else can be asked conceptually. Now let's move to one disorder of the respiratory system, which is basically multi-system disorder, but we often talk about it in the respiratory system, right? So I'm going to talk now about sarcoidosis. Sarcoidosis. Okay, so what is sarcoidosis? Sarcoidosis is a multi-systemic autoimmune, probably autoimmune inflammatory disorder. So it's a multi-system autoimmune inflammatory disorder. Okay, so we're talking about multi-system. So examiner will ask you which system is most commonly affected. That's the first point. So most commonly affected system. The most commonly affected system in sarcoidosis is respiratory system. That is why I am talking about it in the respiratory system. Respiratory system is the most commonly affected system. Okay. Now what is the usual involvement of lungs? The lung involvement will be in the form of hilar lymphadenopathy, plus parenchymal involvement. So there is involvement of the lung parenchyma. Okay, involvement in the form of what? क्या हो रहा है वहाँ पे? The involvement is in the form of granuloma formation. So you have granulomas there. There are granulomas formed in the lymph nodes. There is granulomas formed in the lung. Now think about a disease which also causes granulomas in the lymph nodes and the lung, right? Tuberculosis. So how is it different from tuberculosis? वहाँ पे भी there are granulomas in the lymph nodes and the lungs. Here also there are granulomas in the lymph nodes and lungs. But in case of tuberculosis, you have caseating granulomas. Here the granulomas are non-caseating. Non-caseating. Clear? Okay. Now they will also ask you what is the second most commonly affected organ. Second most common affected organ. So second most commonly affected organ is skin. Skin is the second most commonly affected organ. Now skin में क्या क्या होता है? Dermat faculty will discuss in detail. I'll just remind you of two findings that we typically see in patients with sarcoidosis. Okay, one is erythema nodosum. Okay, and the second one is what is called as lupus pernio. Every time we talk about this lupus pernio in any of the exams, right, at least half of the students mention the cause for lupus pernio as SLE because the word lupus is there, right? But it is not the case. Lupus pernio is a manifestation we see in sarcoidosis on the face. Exactly same malar region. There will be pigmentation in the lupus pernio. Same you see in SLE. The difference is here there are granulomas underneath it, so you will be able to palpate it. There are palpable rash. These are lupus pernio rashes. The SLE malar rash that we see, it's just the erythema and pigmentation. It is not palpable rash. That's the main difference. Okay. Now they will also ask you what is the most common CNS manifestation. So the most common CNS manifestation is seventh nerve palsy. Seventh nerve palsy, because these granulomas which form in the parotid gland can compress the seventh nerve and can cause seventh nerve palsy. That is the most common CNS manifestation. Okay, they can ask you what is the most common renal manifestation. We are talking about a multi-system disorder, so many other systems can be affected. Most common renal manifestation, that is interstitial nephritis. Interstitial nephritis. Okay, now you should also know the staging of sarcoidosis. Staging of sarcoidosis. So what are the staging systems that we follow? Currently we follow a staging system for sarcoidosis which is called as SCADIG staging. SCADIG staging for sarcoidosis. Like they might ask you the name of this. At this point of time, I don't think you should be wasting time trying to understand all the stages, 4 stages of the sarcoidosis, but at least be aware about the names, SCADIG stages of the sarcoidosis. Okay, now extra thing we need to know about is the diagnosis of sarcoidosis. Diagnosis. When you think of sarcoidosis, whenever a patient presents with the lung involvement, because that's the most commonly affected organ, where on the imaging you see that hilar lymph nodes are enlarged and parenchymal changes are present, you start thinking of tuberculosis and sarcoidosis. So we need to differentiate between these two to come to the diagnosis. Okay, so for diagnosis, first thing first, what is important? We need one, blood levels. I will talk about it later. The second thing we need is negative CBNAT or interferon gamma release assay, IGRA test. Why this should be negative? Because we need to rule out tuberculosis, because tuberculosis has exact same clinical picture on the X-ray as well as on the clinical grounds on examination. It is going to be exactly same. So to differentiate, we need to prove that tuberculosis is not there in this patient, and merely doing the sputum microscopy Ziehl-Neelsen stain is not adequate to rule out tuberculosis. That is why we have to do CBNAT or IGRA test. Okay. Then second, serum ACE levels, serum angiotensin convertase enzyme levels, right? They will be increased in patients with the sarcoidosis. So in one of the previous FMGE exam, they have asked this: in which of the following conditions serum ACE levels will be elevated? Your answer should have been sarcoidosis if you knew the diagnostic criteria. Okay. Then the third diagnostic criteria that is required for the diagnosis is the biopsy suggestive of non-caseating granulomas. If it is caseating, then again it is tuberculosis, right? Non-caseating granulomas or typical imaging findings. So if you have done the imaging, there should be typical imaging findings. So then comes the question, what are these typical imaging findings and what is the imaging modality of choice? Should I do chest X-ray? Should I do HRCT? Should I do MRI, or should I do PET-CT or something, right? So the imaging modality of choice, imaging modality of choice for diagnosis of sarcoidosis is number 1, or first in line, is PET-CT. Number 2, if PET-CT is not available, you can think of gallium scan. Okay, either PET-CT or gallium scan. Both are nuclear scans, right? They are not like your simple CT or MRI. Now what are we seeing? What are those typical imaging findings that we will be seeing in these investigations? Those findings are 2 important ones. Number 1, there is a sign called as PANDAS sign. So this can be a potential MCQ. So there is a tracer uptake in the orbit, the nasopharynx, and it makes it, the patient might be looking like the panda's face on the imaging. So we call it as PANDAS sign. And the second one is called as lambda sign, because there are pre and paratracheal lymph nodes involved. Again, that might create the image look of lambda. So that is why it is called as lambda sign. So PANDAS sign and lambda sign are characteristic imaging findings that we see in patients with sarcoidosis. So if that is there, like any patient presenting with respiratory complaints, cough and all, and tuberculosis is ruled out, and on the imaging, on the PET CT or gallium scan, if you get panda sign or lambda sign, we are done with the diagnosis of sarcoidosis. Okay. Now coming to the treatment of sarcoidosis. How do you treat sarcoidosis? Treatment के लिए first point is the drug of choice is corticosteroids. So like pretty easy to remember, no? Respiratory system कुछ भी बोलो, finally if you don't know anything, you can probably pick up corticosteroids as a choice, and you have more than 50% chances of turning out to be correct, right? Drug of choice is corticosteroids. Second line agents, again my answer is standard immunosuppressant. जब steroids काम नहीं करेंगे तो immunosuppressants are always there. Immunosuppressants are second line agents. Okay, so this is about the sarcoidosis. Immunosuppressants are the second line agent. Okay, so these are the important respiratory system disorders that we have quickly touched upon. Glance through the points that I have written here that might come in handy during your exam preparation. Okay, now let's move to the next system. Okay, so we will start with the system. Let us take neurology, at least 1 or 2 diseases we can finish, and then we will do one more session trying to club the cardiology and nephrology. Okay, so in the neurology, first disease we will talk about is, I'll give you a clue, you should be able to answer. The most common neurodegenerative disorder. Right, we are talking about Alzheimer's disease. Alzheimer's. I will only focus on what can be asked as an MCQ point instead of making it a very elaborate discussion on Alzheimer's disease. Okay, so the first point you need to know is this is the most common neurodegenerative disorder. This is far more common than we people are aware or recognize in our day-to-day practice. This is the most common neurodegenerative disorder. Just because we're talking about what is the most common, we will also talk about what is the second most common neurodegenerative disorder. See, we are not talking about common neurological disorder. If you ask what is common neurological disorder, sir dard, headache is the most common neurological disorder. But we are talking about neurodegenerative disorders where the neurons are getting destroyed, degenerated. So the second most common neurodegenerative disorder is Parkinson's disease. Second most common is Parkinson's disease. Okay, so that is one point. Then they will ask you the genetic conditions which increase the risk of developing Alzheimer's disease. Okay, genetic conditions that predispose the risk of Alzheimer's disease. I will tell you 3 points to remember. First point is a gene called as presenilin 1. Presenilin 1 mutation. Right, so name says pre. Senile means senile. Senile means getting older, right? Pre means like early. So whatever memory loss that would happen as part and parcel of aging, that is happening much early, right? That is what the meaning of presenilin means. So mutation of this presenilin can be a risk factor for Alzheimer's disease. Okay. Then the second risk factor for development of Alzheimer's disease with respect to genetics is a variation in the ApoE gene, right? So particularly ApoE4 variant, those who have on their both chromosomes the E4 variant of the apolipoprotein gene E, that they carry the higher risk of developing Alzheimer's disease. Okay, and third, there is a syndrome which is associated with increased risk of Alzheimer's disease. No guessing here, it is Down syndrome. Down syndrome is associated with much higher risk of developing Alzheimer's disease than anyone who doesn't have Down syndrome. Okay. Then they will ask you the earliest site in the brain to get affected in Alzheimer's disease. Earliest site to get affected where neurodegeneration is happening, and that is entorhinal cortex. Entorhinal cortex. Okay. They will ask you what is the earliest symptom. Earliest symptom of Alzheimer's disease, dementia, right? To be more precise, memory loss. Memory loss. And then they will ask you among the memory whether it is the immediate memory or the recent memory or the remote memory that is affected. So usually the most commonly affected one is recent memory. Recent memory gets affected first, and quite late in the course there will be remote memory affected. So first to get affected is your recent memory. Okay. Now I'm not getting into the treatment of Alzheimer's disease because pharmacology they will cover. Primarily focus on there are some recently approved FDA approved drugs, right? One is targeting the amyloid beta protein, and there is another which is mainly approved for the treatment of agitation. That will be covered in pharmacology. I will give you a few more points about the Alzheimer's disease, and then we will wind up for today, and then we will connect tomorrow to in the next session to discuss some more important points. Okay, what extra they can ask you is which metal toxicity is associated with the risk of Alzheimer's disease. Metal toxicity with increased Alzheimer's disease risk, and that is aluminium. Okay, and just because we are talking about the metal and toxicity, there is a metal toxicity which is associated with increased risk of Parkinson's disease. That can also be a question. Metal toxicity with increased risk of Parkinson's disease. Your answer should be manganese, not magnesium, manganese. So manganese Parkinson's disease and aluminium Alzheimer's disease. कंफ्यूज होता है? नहीं होगा, क्योंकि A for Alzheimer's, aluminium for Alzheimer's, जो भी बचा है मैंगनीज पार्किंसन को दे दो. A for Alzheimer's. Okay, last point before we wind up guys, the diagnosis के लिए in one of the MCQ FMGE MCQ there was a statement saying that we need to go for MRI or PET CT. The answer is no. The diagnosis is clinical. Only if you have doubt about other closely related differential diagnosis, you need to go for the imaging. So the diagnosis is clinical, right? So what do I mean by clinical? Patient should have cognitive dysfunction on your cognitive assessment tools like the mini mental status examination, and you should rule out other causes for dementia like multi-infarct dementia, nutritional deficiencies like B12 deficiency, Wernicke-Korsakoff psychosis, B1 deficiency, right, niacin deficiency leading to pellagra. Those things, or what we call as reversible causes for dementia, should be ruled out. Okay, guys, because we're talking, let me just put few points about reversible causes for dementia, and then I'll sign off for today. I'll see you tomorrow again. Reversible causes for dementia is again an important MCQ point. Reversible causes for dementia. Okay, B1, B12, niacin deficiency. Okay, hypothyroidism. Okay, then normal pressure hydrocephalus. And CNS infections. So these are all reversible causes for dementia. Patient might have dementia, but once you treat the underlying cause, they can bounce back to normalcy. Okay, so I hope these points are helpful. Take a quick look at all the written points. I'll share the PDF in the Telegram group, and hopefully we will connect with one more session, and we will try to cover 3 or 4 important diseases from the neurology, and similarly important diseases from cardiology and nephrology. Hopefully that should give you some at least 4 or 5 important MCQs for the upcoming examination. Please don't miss out on all the sessions conducted by my colleagues, and also try to give these FMGE tests. This test, don't take it to heart. This is not the test to assess your performance. These are the tests to get yourself acquainted with the exam pattern or exam mentality. We need to get into an exam mode, right? Otherwise, we will do a lot of mistakes in the examination hall. So do those mistakes in these tests, and in the examination hall, be confident and do well. All the best guys. I'll see you soon with the next video module. Till then, have a good time. Thank you.